Hey guys, so otitis media. Look, treating otitis media should be core business in pediatric emergency medicine. And if you ask any adult who's had otitis media, they will tell you it's exquisitely painful. And so pressure to prescribe antibiotics in the hope that it might shorten the length of pain is pretty reasonable. And if you actually ask many ENT physicians, I've found anecdotally that they say go for it. But I think there's more to the story. So let's establish a couple of facts about otitis media to start with. So firstly, it is common. About 90% of kids will have had an ear infection by 6 years of age. The majority of otitis media is actually a combination of viral and bacterial etiology. So about 2/3 are a combination of a virus and a bacteria. About 1/3 are solely bacteria, and actually less than 5% are just purely viral. Otitis media is a result of eustachian tube dysfunction. So you get a virus, the immune system and discharge means too that your nasopharynx gets blocked up, and the normal bacterial colonizers, which is strep pneumonia, Haemophilus influenzae, and Moraxella catarrhalis, enter the eustachian tube. That causes pressure, and then that causes pain. Most children, no matter what you do, will recover within 24 hours. And then while it's mostly benign and self-limiting, there are a number of serious complications. So mastoiditis occurs in about 1 in 1,000 cases in developed countries, and it's more common in indigenous children. Very rarely, you can also get meningitis, brain abscess, facial nerve palsies, and lateral sinus thrombosis. So importantly, those complications are so rare that it's hard to get evidence whether you can prevent them with antibiotics or not, because your study population size would need to be huge, and we're unlikely to get convincing evidence of it anytime soon. So let's look at what we do have, which is a Cochrane review entitled Antibiotics for Acute Otitis Media in Children, published in June 2015, and it is a Cochrane systematic review. So, from their systematic review of antibiotics versus placebo for otitis media, they found 13 RCTs with 3,400 kids and 4,000 otitis media episodes, and they were based in high-income countries, which is relevant to us in Australia. The combined results revealed that by 24 hours from the start of treatment, 60% of kids had no symptoms and had recovered. So for the majority of kids in our ED, if we did nothing but give them pain relief, they'd be pain-free in 24 hours without antibiotics. The review did find that to have one child with less pain at day 2 or 3, you'd need to treat 20 kids. Antibiotics did have some effect on the kids who were left with pain at days 4 to day 12. Antibiotics did reduce the number of children with abnormal tympanometry findings at 2 to 8 weeks, and the number of children with eardrum perforations, and halved the progress of unilateral otitis media to bilateral otitis media compared with placebo. So it's not like the antibiotics are doing nothing, it's just that the natural history is for this to get better. So the benefits of antibiotics actually become increasingly small. And when we look at long-term stuff, the benefits are even less impressive. So antibiotics did not reduce the number of kids with abnormal tympanometry findings at 3 months, so their ears looked the same at 3 months. And severe complications were rare, and the outcomes didn't differ between children treated with antibiotics and those treated with placebo. Whether that's because those things are so rare we can't prove it, or whether or not antibiotics don't make a difference is a different question. So from this, it seems pretty reasonable that for kids in a first world setting without an ethnic predisposition to complications, so kids like Indigenous and Torres Strait Islander kids, then I'd argue that it's reasonable to not treat most kids with antibiotics. But it's not a rule. We do need to think about how many drugs we need to prescribe, though, in order to make one of the kids we see get better. In addition to that, we've got to think about the bad outcomes. So when we look at the adverse effects from antibiotics, such as vomiting, diarrhea, or rash, that occurred more often in kids taking antibiotics. And so if the number needed to harm, it was 14. So for every 14 kids, you're creating a negative side effect of those antibiotics. So it'd be easy to say, that's the whole picture and stop giving antibiotics for otitis media. But it's not the whole picture because things get more detailed in the subanalysis. So on individual meta-analysis of a subset of trials, the number needed to treat for benefit changes for different types of otitis media. And in particular, antibiotics were most beneficial in kids who were less than 2 who had bilateral otitis media. And for those kids, the number needed to treat was 4. So for every 4 kids we treat, 1 of them will have less pain, which starts to sound a lot more reasonable. Even better, those who had otitis media and otorrhea, so discharge, their number needed to benefit was 3. So to me, treating 4 kids for 1 of them to have less pain is a lot more reasonable than treating 20. So if I see a kid under 2 with bilateral otitis media, or with otitis media and otorrhea, then I'm going to feel more comfortable treating them with antibiotics and more comfortable withholding it in other patient populations. And then for me personally, for Indigenous kids, my strategy will be very different, which is going to be throw antibiotics at them because their risk of chronic perforation and hearing loss is very, very different. So my threshold is going to change based on their ethnic background as well. So that's the evidence that I've read for antibiotics in otitis media. You might have a different perspective, but I think knowing those numbers needed to treat can be really helpful in making a decision about what you're going to do. The other thing to know is that there is a separate, I think, British trial which shows that giving people a delayed script to start prescribing, so they take home and then fill if their child is still having antibiotics, still having pain in 24 hours time, is a potential strategy as well, in that most parents did not fill that script because their child did get better. So that is a potential collaborative strategy that you could use to work with the families in a way they find acceptable if they're really, really pushing for antibiotics. Overall, I think it's not a hard and fast rule, but most of the kids in our department who have otitis media probably don't need to be going home with antibiotics, and there'll be a subset that's much more reasonable for us to treat. Cheers.